Good morning, everybody. Happy Tuesday morning. Welcome to PCH Grand Rounds. Our speaker this morning is Dr. Stephen Brown, and as you guys may have noticed, it's a special day, special Grand Rounds. Today is the inaugural PCH Quality Day, and Dr. Brown's presentation is really the first event to kind of kick off all the events this morning for Quality Day. Dr. Brown is the program director of the Family Medicine Residency Program at U of A College of Medicine, Phoenix. He spoke at Grand Rounds a year ago, and I have been wanting him to come back ever since. And quite frankly, I've been wanting to get as big of an audience here to listen to him as possible, just because I was so impressed with everything he had to say last year. So we're excited to have Dr. Brown this morning. The kind of foundation of Quality Day at PCH was a QI project abstract competition. And that competition was really the brainchild of Dr. Brown. He started it at U of A College of Medicine and Banner University 3 or 4 years ago, 2013. That idea and that competition has won national recognition. Dr. Brown was really gracious enough to fully support and embrace us stealing his idea here at Phoenix Children's. We're very glad that he can be part of the events today. So this competition that I'm referring to, we actually had 53 abstract submissions. They were basically 50-50. Half of them were in the new idea, high value category, and the other half were in the ongoing/completed category. That was way more than we were expecting. So we were super excited to get so much interest from the whole hospital. And it was from trainees, it was from attendings, it was from nurses, it was from interpreters, patient transport. We just had a very diverse group of authors for our abstract submissions. So you can see some of the posters in the room here. And then at lunchtime, we will have some of the 5 of the finalists give a 10-minute oral presentation, and then we will announce the winners at the end of the presentations at lunch. So we'll have lunch catered as well, so please join us at the lunch hour, and I think it'll be really exciting to hear the top 5 finalists in both categories. So without further ado, let me welcome Dr. Stephen Brown.
Thank you. It's a huge honor to be here. Our family medicine residency, as most of you know, is just down the road at the hospital formerly known as Good Sam. We're able to recruit residents nationally, and part of the reason for that is that we have such great pediatrics training at our residency, and a big part of that is because of the Dr. Bavaraju and her excellent pediatric residency here. So we thank you all so much for working with our family medicine residents and teaching, and it's a huge part of what makes our residency great, and it's a great collaboration. So I'm hugely honored to be here. Thank you. Okay, so we're going to talk about the value crisis and approaches to improve quality and value in American healthcare. We're going to talk about high-value educational interventions and how you can implement quality or value projects in your own work setting. So this will be a graph that will be very familiar to many of you. Our health system is not as high quality as it should be and costs way too much. So you can see that we are a strong outlier as far as health spending per capita, but that we don't get improved outcomes based on that. I think we all would accept, well, maybe a lot of us would accept spending more money if we had good outcomes, but that is not the case. And so in 2001, the Institute of Medicine came out with a report that said the difference between the healthcare we have and what we should have in this country is not a gap, but a chasm. And here are the 6 aims that the Institute of Medicine came up with for improving American healthcare. It should be more safe, effective, patient-centered, timely, efficient, and equitable. Many of us have been patients at this point, and all of us are healthcare providers, but we all know what do our patients experience in this system? A lot of waiting, a lot of inefficiencies, Certainly you all see the inequity in our health system. But as doctors also, it's incredibly frustrating many times to work in this system. We spend a lot of time working with electronic things and paperwork, and not the time that we want to spend with our patients. So there's lots of ways that we could be improving U.S. healthcare. I'm going to start with talking about quality. So I like this graph because it's like literally the most simple graph that you could possibly have. So this is from a RAND study published in the New England Journal of Medicine that looks at how well we achieve quality healthcare in this country, and this is for a whole variety of metrics, and you can see that only about half the time do we provide care that meets quality recommendations. And so this is mostly related to adults here, but you can see what the impact of us not achieving quality care, what the impact of that is. So patients go blind, they have kidney failure because they don't control their diabetes, they die because their hypertension is out of control, they die because they don't get a pneumonia shot. So this is not just theoretical. When we don't meet quality, when we don't provide quality health care, our patients and the health of our country suffers. This is total hospital stays for preventable conditions. And if you just look at the far right bar, and that's in thousands. So we're talking about millions of preventable hospital admissions. So, and this is way back to 2004, but you can see that there's over 4 million preventable hospital admissions in this country annually. And you can, I'm sure, all think of a kid that you've taken care of in the hospital that probably didn't need to be there, and really it was completely preventable. So just in case you think, oh, well, he's just giving us data all from adults, and I know that our pediatric quality care is much higher. This is the similar group did the study in the New England Journal. They came up with a bunch of quality metrics, which we're going to talk a little bit about more. But you can see that similarly, for kids in this study, only about half of the indicated quality care was received. So let's talk about cost. So that's a little bit of a background on quality. Again, no one needs to see the curve that shows that our healthcare expenditures are galloping out of control in this country. In 2014, it was $9,523 per person, or 17.5% of GDP. This is unsustainable. Here is that same graph that I showed you earlier about preventable hospitalizations, but now we're going to put a dollar value on it, and the y-axis here is billions. So if you look at the total number of admissions, basically $29 billion a year just in these conditions for preventable hospitalizations. And a big part of, so now about 50% of healthcare in this country is paid for by the US government. And it's a huge problem for the government. There's lots of other things that we could be spending that money on, Meals on Wheels, or libraries, or roads, bridges. But it's not only a problem for the government, and it's not only a problem for us. Most of us have employer-sponsored insurance, so we don't have as maybe big of a copay, but there are families that literally can't buy insurance because it's so expensive. So it's a problem for the government, it's a problem for individuals, which we'll talk about a little bit, but it's a huge problem for American business. $2,500 of every GM car is healthcare. $1,900 of every GM car is retiree healthcare. So this is a huge disadvantage for American businesses. Starbucks spends more on healthcare than they spend on coffee beans. And that's because Starbucks is a relatively progressive company that will actually buy health insurance even for its part-time workers. So this is so if you think about your $4.50 latte that you got, probably a buck or two of that is is healthcare for employees. So thank you for supporting healthcare for Starbucks employees with your overly expensive beverage. Because of the cost of healthcare, our patients often make choices that lead to suboptimal care. So this is a study from 2016 from the Kaiser Family Foundation where they interviewed patients and asked them, based on cost, did they skip certain treatments? And you can see that about a third of patients skipped dental care. People did not go to the doctor. They postponed getting the health care they needed. They skipped a test. They didn't fill a prescription. They cut their pills in half or skipped a dose, or they had problems getting mental health care. So the cost of health care, and you all working at this hospital know this as well as anyone in the country, that our patients don't get the care they need often because of the barriers of cost. And this is not a secret anymore. This is not only something that's known within, among healthcare professionals, but it's really a national crisis. And we've now heard, solutions from both parties about how maybe we could insure more or less people in some cases, but the cost and that it's a huge issue for our country for so many reasons, like I outlined. Okay, so here's that same graph that I showed you earlier. Safe, effective, timely, patient-centered, equitable, efficient. And you can see that there are two problems when it comes to effectiveness. You can have both underuse and overuse. So not only do people get the care they need, but they also need the care they get. So both underuse and overuse are, ironically, major problems in American medicine. There's a whole group of people that are not getting care that will clearly save their lives, and then there's a whole group of people that are getting way too much care that's harming them, and we'll talk about that more. Waste alone is $750 billion in this country. It's about 20 to 30% of our healthcare expenditures is just waste. And that means something that will not benefit a patient in any way. And again, I think many of you can think of examples of this from your own work. So this leads us to a very simple equation. Value is the quality of the care that you deliver divided by the cost that it costs to deliver that care. And so if you want to improve the value of healthcare, which we so desperately need to do, we either need to make it better or we need to make it cost less. And this was really the basis of our contest that we started, that is, the seed for your quality day that you're having today. Dr. Willis tells me that a lot of the finalists are going to be receiving this book, which I highly recommend, Understanding Value-Based Healthcare. This is by the authors started a nonprofit in the U.S. called Costs of Care. If you're a Twitter person, you can find it at Costs of Care. And they actually came, Neil Shaw, one of the authors of this, came to our first quality day at Good Sam. And there's a great quote from the introduction where a seasoned dean at UCSF stands up in front of a group of medical students and he says, you young medical students in your career will be under relentless pressure to deliver the highest quality, safest, most satisfying care at the lowest possible cost. And he sits there and lets that sink in, the gravitas of the comment. And then one of the medical students raises his hand and says, "What exactly were you trying to do?" And it's true, right? We for generations, years, have just felt like, I'm going to do everything for the patient sitting in front of me, and that's my job. And it is an absolute imperative that we start to think more globally when it comes to the care of our patients. And you could make a pretty good, so just spending more money on a patient does not improve the outcome. In fact, as you can see from this equation, if you're not increasing the quality by spending more money, then your value is actually going down. Okay, So this is the IHI triple aim, and this is a big topic in the primary care world because primary care is basically the way that we can achieve the triple aim in U.S. healthcare. We can improve the overall health of the population, the experience of care. Sometimes people put quality down in that lower corner with the experience of care, and decrease per capita health costs. We can do that with primary care. We can do that by getting rid of waste. We can do that in lots of ways. The people have also now started to talk, just as an aside, people have started talking about the quadruple aim, which includes improving the satisfaction of the people providing the care. So if our doctors and nurses are burning out because they're, running on the hamster wheel to try to, improve the other parts of the triple aim, then they're not going to last very long. And we've seen that as a huge problem in American medicine also, is burnout. Okay, so let's go back to quality again, because this is sometimes a really hard thing to wrap our arms around. So this is a very boring definition of quality from the IOM, which I think would ring true for most of us. Increasing the likelihood of desired health outcomes. So this is the big problem with quality. Not everything that counts can be counted, and not everything that can be counted counts. So you have all been subject to some measure that you look at and you're like, well, that measure doesn't make it. Why am I, and almost every measure has unintended consequences, right? So you're measuring one thing and you end up doing something else that's not really helpful. And so this is a huge challenge, is that if you want to know if I'm delivering high quality healthcare, you have to have some way of measuring that, which can be very elusive. So here's another sort of boring definition of what quality is. You have to know who is sort of responsible for that. The measurement has to be rigorous, systematic, quantifiable. It can't be a random quality measure. And so a lot of our specialty organizations, national governmental organizations come together to decide what really is quality healthcare, and sometimes they frankly just get it wrong. A classic example is that in an adult, I don't know if they have a similar one in peds, but in adult, a patient admitted for pneumonia, they have to get their antibiotics within 4 hours, right? And so that sounds like a pretty good idea. But the unintended consequence of that is a lot of times you don't know if the patient has pneumonia within 4 hours, but then like 6 hours you're like, oh wait, my patient had pneumonia. So you just start giving antibiotics to everybody, even if they have a slight chance of having pneumonia when they get to the ER. So, and that was a Medicare measurement. So sometimes we just fail miserably on those. All right, so you guys are now going to be the quality metric gurus. So turn to your neighbor, and you get to pick several quality metrics, either for a 5-year-old that is admitted for asthma or a 1-year-old seen in the clinic for ear pain. You can pick either one of these, talk to your neighbor for a few minutes, come up with a few things that you think would be good quality measures for these conditions. All right. You solved the problem, Dr. Steelbaugh? Okay, so who came up with some good quality metrics for a 5-year-old admitted for asthma exacerbation? Yes.
We talked about overall, we'd like to measure length of stay.
Okay, good.
And then measure things that we are known to be helpful, like corticosteroids, albuterol. And then measuring things that are known not to be
Yeah.
helpful, and trying to decrease that.
So like what is not helpful?
X-rays
Good.
for all exacerbations, or
So you came up, and all of those things are reasonably simply measured, right? So like you'd set a standard for the prednisone dose or something, or prednisolone, it would need to be at least a certain amount, mg per kg, or, yeah. Okay, good. What else did you have for asthma?
Tracking long-term things like number of admissions or what the mean is in a 5-year period.
Great. So did the patient have to come back in? There are several quality metrics related to following up a patient that's been admitted. So if they were admitted to the hospital, did they have a follow-up appointment in clinic within 7 days, something like that? Yeah. Good. Right, right. Okay, one more on asthma.
That we administered dexamethasone in the triage to reduce the length of stay and also ensure across the board equal asthma education throughout to see if that decreases admission rates.
Great. So some kind of metric about making sure that everybody gets a visit from an educator within a day or two or something like that. Yeah, that sounds great. Okay, so did anyone talk about ear pain? What do you think are the quality metrics for ear pain? Yes.
Measuring the proportion of children that are treated with the appropriate antibiotic for bad.
Great. Which guideline would you choose? Yeah. Of course. Yeah. And actually, we're going to get to that a little bit later. And so when you say appropriate antibiotic, what do you mean?
So for a kid that hasn't had an ear infection in the last 30 days, or in some cases not even an antibiotic,
Right.
but generally like a month.
Yeah, how about percentage of kids over age 2 that received watchful waiting as their plan for their otitis media? Anything else on the ear? So literally, like, you guys just created the quality measures, and really not that much more complicated than that, which is, and so so that study that I showed you that was published in the New England Journal that said what percentage of quality metrics are reached in pediatric care, and it was less than half. Almost all of the quality metrics that this like esteemed group chose were from lower level evidence. So you really would like quality metrics to, one of the things that you saw on that slide was it should meet evidence-based care, right? We shouldn't be making metrics based on shoddy research. But then you have to come up with something, and then there are things like asthma education, which might prove a little more elusive to prove that that's helpful, but we think that it probably is helpful, and so we can make metrics. But the more you make non-evidence-based recommendations, the harder it is then you get people, frustrated. But so basically you guys did exactly what they do at national organizations when they come up with how are we going to measure your care. And one of the things that we'll talk about when we talk about professionalism is that it's our responsibility to be at the table when those decisions are being made. Okay, so that's really great. Quality, why are you telling me all this? And the answer is because it's our professional responsibility to improve the quality and value of care for our patients, for our hospital systems, and for our country. What a profession the definition of a profession is that we get to regulate ourselves, and also that there's a certain standard. So if you go into a hospital in Des Moines, Iowa, and someone says, "Hello, I'm your nurse today," we all know that there's going to be some standard that nurse has met to be there. Same with the doctor. They may not be the best nurse and the best doctor ever, but they've met some kind of criteria. Because we're a profession, we can regulate ourselves. We get to determine what it means to be a nurse or a doctor. And so that's our responsibility that's our privilege as professionals. Our responsibility is that one of the things about a profession is that there's often somebody else that you're putting first. In the case of healthcare, it's the patient. Our professional responsibility, the pledge that we all make, is that the patient comes first. And so Howard Brody, who's a family physician and ethicist who started the Choosing Wisely campaign, which I talked to you about last year and which we're going to talk a little bit about later today, said that, in fact, eliminating wasteful, non-beneficial interventions is part of our ethical responsibility. So really long statements. I'm not going to read you the whole things. This is from the American Academy of Pediatrics statement on professionalism, that we are responsible ultimately to society, and that is our professional responsibility to collaborate in the search for systematic actions to prevent harms. This is in looking at error. And then it's also, AAP also says that we're responsible to communities, that we are responsible for an effective use of healthcare and public health resources. This is from the American Academy of Pediatrics. The American Board of Internal Medicine Foundation, which many have accepted as kind of the gold standard of a professionalism standard, has taken it even further this will not be surprising, that we're responsible for continuous improvement in the quality of healthcare. We should minimize overuse of healthcare resources, but they take it even further and say that we should be committed to a just distribution of finite resources. You hardly ever hear people, this is one of the big problems with our system. We hardly ever hear people talking about finite resources. We have not come to that place in American medicine yet, but we should and we will, and we need to be ready. We need to be ready when the system forces us to do this. If we do it right, we could do it before the system forces us to do it in the way that we would like it to be done, rather than the way that the system tells us. So, looking further down, the physician's professional responsibility for appropriate allocation of resources requires scrupulous avoidance of superfluous tests and procedures. I loved whoever was writing that day, scrupulous and superfluous. Who's in the best position to help address the problem of unnecessary tests or procedures? I should have had the audience response system. No one's going to say, the government. That's what I believe in right now, the government. And this was a study done by the Choosing Wisely campaign, and basically, this is a survey of physicians, and physicians largely agree that we are in the best position to help address the problem of unnecessary tests and procedures. This is an editorial in the New England Journal of Medicine about consciousness in patient care and what is medical education's responsibility. And this is just a quote: "We must be honest about the choices we make every day and stop hiding behind the myth that every physician should and does apply every resource in unlimited degree to every patient for even minimal potential benefit." So this is on us, Vasu, for teaching our upcoming, the future of American healthcare. This is on us right here. So not only should we be practicing this, but we should be teaching this. And so this is you think globally, but act locally. So here are 5 steps this is from the American College of Physicians, 5 steps for practicing high-value care. And we're going to break these down a little bit. So number 1 is you have to understand the benefits, harms, and the costs of the interventions you're considering. Number 2, decrease or eliminate use of interventions that provide no benefit. You all can think of something that you did, possibly within the last 24 hours, that provided no benefit to your patient or potentially was even harmful. We should choose interventions at care settings that maximize benefits, minimize harms, reduce cost, use comparative effectiveness and cost effectiveness data when available. Step 4, this is often the most challenging but can be very high yield, is shared decision making with families about cost and value and quality. And then finally, step 5, which you guys are all doing today by coming to your first quality day, is to identify system-level opportunities to improve outcomes, minimize harms, and reduce waste. And it's really impressive that for your guys' first year, you had 53 entries in the contest, which is just really excellent and really great posters here. And I'm sure the talks this afternoon will be amazing. We found that a lot of these ideas come best from the people that are on the front lines, which is all of you. All right, so let's go through some examples. So step 1, understand benefits, harms, and relative costs of interventions you are considering. And one example of the way that you can do this is you can become a high-value medication prescriber. 10% of the cost of American healthcare, $259 billion a year, is on prescription drugs. So maybe we could just, by being high-value prescribers, we could probably just about cut this piece of the pie in half. And there are lots of ways to do this. One of them is by every time you think about giving a new medication, you should compare it to an old, cheap, standard medication and figure out, is it actually better by these 5 criteria, the STEPS criteria: safety, tolerability, effectiveness, price, and simplicity. These are the only 5 rational reasons to prescribe a medication. Lots of times you'll hear people saying, oh, cardiologist down the street prescribes it, so I should be prescribing it. That's not a good reason. It's the #1 new antibiotic for so-and-so. That's not a good reason. There's only 5 reasons that you should be prescribing a new medication, and you should use STEPS. And the hardest part of this is the price. We often don't consider this, but we should. Anytime you do anything, you need to think about what the price of that is. And so many of you know there's an app for this. You can look at it online anytime, goodrx.com. You can sit in the room with your patients. You can compare the different costs, and it'll tell you literally there's like a CVS down the street where it's $4 a month for this medication. So if we don't ask our patients about price and whether they can afford it and do they have barriers to their medications, then we're not going to find out and they're going to get suboptimal care. So here's an example from Metformin, which everybody knows is a medication for type 2 diabetes. It's a very safe drug, only a slight possible contraindication for low renal function. Tolerability, some diarrhea, some nausea, vomiting, no weight gain. It's quite effective in the adult population. It's been the only medication shown to decrease cardiovascular outcomes. The price is it's cheap, and the simplicity is it's twice a day oral. So there's an example of STEPS for Metformin. Questions or comments about being a high-value prescriber? I wrote in an editorial, I don't know if I want to say this in front of this group, but 7 years ago, we got rid of drug reps in our office because they are, let's just say they're not in the business of high-value prescribing. Maybe value for them or their company. Okay, so step 2, decrease or eliminate the use of interventions that provide no benefit and may be harmful. And I talked last year to you all about the Choosing Wisely campaign. This has been one of the most successful kind of, physician-led public health campaigns ever that I know of. All these specialty societies signed on, and they came up with lists of things not to do. So this is not like the insurance company or your hospital or your CMO or telling you not to do something. This is your own specialty society telling you what is wasteful. And so you can see all these pediatric organizations that signed on, and I'll just give you some examples and then go into a little more detail here. So don't do a whole bunch of diagnostic tests for allergy. Don't put in ear tubes if it's been less than 3 months with just a single episode. Don't screen adolescents for scoliosis. Here's our don't prescribe antibiotics. This is one of my favorite. Don't prescribe antibiotics for otitis media in children aged 2 to 12 with non-severe symptoms where the observation option is reasonable. So watchful waiting is a really good option for otitis media. You don't need an x-ray every day for a kid that's intubated. We'll talk a little bit more about the CT scans. Don't give medications to treat insomnia in kids. You should be doing oral rehydration first in the ER. And don't give reflux medications to happy spitters. All right, so let's go into a little more detail on 2 of these. So CT scans are massively, over the last decade, have massively increased in use and have numerous potential harms, not the least of which is that you cause cancer by radiating people, especially children. And the more radiation you give from the more, like for example, an abdominal pelvis CT in a 5-year-old girl, you have like a number needed to harm of like 500. For every 500 of those that you do, you will cause 1 cancer. So it's not only this is another example of it's not only a question of reducing waste because it is expensive, it's preventing harm. And so if you need a CT scan, you should get a CT scan, but many times you don't. And many times we don't use the tools that we have to decide that somebody doesn't need a CT scan. So this is a perfect example. In a child with a minor head injury, there's a criteria that you can use, validated criteria to determine which kids do not need head CTs. So my residents say that you guys do a pretty good job of most of this stuff here at PCH. So I may be preaching to the choir, but many kids do not need head CTs for their minor head injuries. Similarly, and I also understand that from our residents, this is something that you guys have done really well in, is the first test for suspected appendicitis in a kid should absolutely be an ultrasound. It's a highly specific test. If it's positive for ABI, you have ruled in appendicitis. You do not need a CT scan. So this is another thing. So again, this is not me telling you this. This is not the CMO telling you this. This is your own specialty societies telling you, do not do a CT scan. Yes? What are the number of websites I pulled this from a list of 5 things, so that's the 4th thing on the list, but they all are referenced, so they will give you what study it is and why it's recommended or what guideline it's recommended in. Was there another comment? Am I getting controversial now? And you can even, this is like pretty wishy-washy, right? Anytime you see the word consider, like if you go to a guideline and it's like, you should consider doing this, you're like, yes, that's why I'm reading the guideline, because I'm considering it. So, don't do a CT until you've considered an ultrasound. Do you have ultrasound available 24/7 here? That's great. Because when I talk to family docs about this, especially rural family docs, they'll say, well, the CT scan, they have a technologist there, 24/7 for that, because someone just has to push a few buttons. But the ultrasound requires, an expert technique to do it, and so you have to have someone there 24/7. So this may be something that's easier to do in an urban setting than in a rural setting. But anyway, you get the idea. So this is choosing wisely, things not to do, things that are certainly not going to be beneficial and may be harmful. So then there's 2 here related to bronchiolitis. Again, I didn't come up with these. This is the Society of Hospital Medicine, the pediatric division of the Society of Hospital Medicine. Don't do chest radiographs in children with uncomplicated asthma or bronchiolitis. Don't routinely use bronchodilators in children with bronchiolitis. I know you guys have a protocol where you might try it, but if it didn't work, you stop. So this is a huge area where we could improve care in the U.S. And so skipping ahead to step 5, once you have seen these individual approaches, are you just going to do that yourself? Because lots of times you'll run into a ton of barriers, right? Like if you're the intern and your senior resident really loves to get x-rays on every kid with bronchiolitis, then you're probably not going to really be able to stop doing that. Or how many tests have you ordered as a resident because you're afraid that the attending is going to say like, well, why didn't you do the CT scan? So we can all blame each other for why we're not doing something, but at some point we just have to like step up and become the change you want to see in the world. I did a study where, so one of the things that is incredibly wasteful, maybe you don't see this as much here, but preoperative testing for so a patient of mine is getting like a meniscal repair, which by the way is probably not indicated, but let's just say it was. So then I get a checkbox thing from the orthopedist saying you got to do all these tests, right? They need an EKG, they need a BMP, they need a CBC, whatever. And so this drove me insane. It was so wasteful, and I would call the surgeons and I'd say, why are we doing this? And so I did a qualitative study where I went around and talked to primary care doctors, surgeons, anesthesiologists, and nurses. And I said, why are we doing this? And the primary care doctor said, because the surgeon told me I have to. And the surgeon said, you know what they say? Because the anesthesiologists tell me that I have to. And then I asked the anesthesiologist, and they're like, nah. I'm totally serious. And there's a guideline from the American Society of Anesthesiology that most of the anesthesiologists didn't even know about, saying you don't need all these preoperative tests. And so the surgeons, their worst case scenario is their case is canceled, right? And so they're doing all these tests just to prevent their case being like a 1 in 10 chance of their case being canceled. So anyway, it's insane. So the point is you can't always just become the change you want to see in the world yourself, because there's so many other actors in a system, and especially in a complex system like Phoenix Children's. So this is what Duke did. This is the Duke high-value collaboration with bronchiolitis. And this doesn't really explain what they do, except that it puts like circles that make it look like less tests are ordered here. But the idea is that if we're all just acting in our own little areas, and somehow we think like, oh, well, the hospitalist isn't going to admit the patient until I get a chest x-ray, and then that's going to like worsen my flow in my ER. So, the point is there's somehow we need to get into some kind of coordinated approach to taking care of all these things, because we may not be able to just do it by ourselves. And so that's a big part of why you have what you have today, which is collaborating, getting together, address quality, these kinds of things. All right. So let me tell you briefly about our contest that we started 4 years ago. There was a national call for ways to teach value to house staff. And it was a national contest. And so many of you will know Cheryl O'Malley, the internal medicine program director there. She and I got together and decided that we were going to have our own contest. It's very meta. A contest to enter the contest. And so we did a similar thing that you did, was we gave a cash prize to our house staff for the best idea to improve value. We selected 3 of them in the fall. We gave them a nice cash prize and the support of the institution to help them implement their idea. And then we had them compete in the spring for who did the best job of implementing their idea for another cash prize. And this was, so we won our contest won the national, was one of the finalists in the national contest for the high value idea. And so here we now have had 4 years of this, and here are 4 winners over the years. And here's just some examples of some of the projects that they did, which I won't read all of them to you, but many of them were opportunities to save millions of dollars and to improve the quality of care at the same time. So there are other ideas that have come out of other institutions. One of the ones so this one was published, the Yale Interactive Cost Awareness Exercise. If you are going to publish something, you should come up with a clever mnemonic. It helps. I care. And so what they did was they had a contest between you guys have morning report, yes? So at morning report, they added a cost element. How should we work this patient up? And let's consider cost. And they had a contest between the attendings and the residents for who could come up with the most cost-effective but still appropriate workup. And the residents loved it. There's a survey that shows, but actually the attending physicians did much better, $1,000 versus $4,200 for the residents, which I don't know if I totally believe, because the residents were probably just like, well, my attending told me I had to get a whatever unnecessary test it was. But anyway, they did this at Yale, and it was a little contest for who could come up with the best a workup for a real patient that you are actually seeing that day. Okay, so then an idea out of Denver has actually turned into a published series, which is the JAMA Teachable Moments, which if you haven't seen those, they're really excellent. They're basically like asking residents or fellows to reflect on a patient that they saw that was like out of control costs, and we've all seen the cascade where you get this one unnecessary test that leads to another unnecessary test and so on. So that would be another idea would be to have people write about a patient that they saw where they felt that the value was low. And when you're in clinic, instead of just the SOAP format, you can use the SOAP V format, the V being for value. So at the end of the presentation, then the medical student or resident is required to say what were they pondering with regard to value, like how much does this MRI cost versus not doing an MRI, or why should I not send my patient with a locking knee to the orthopedist because fixing a meniscal tear doesn't even help. So for example, those kinds of things. And then actually they do this at, I don't know if you've ever seen this at Maricopa, but maybe it was medicine. They actually looked at their patient's hospital bill, which is like mind-blowing, right? Because it's like completely unintelligible. And we are the people that like ordered the things, but it's still completely unintelligible. So that is a really useful thing that has been done at other places. I won't go over this much, but you all know the stages of quality improvement. The point of quality improvement is not that you need to all of a sudden implement some huge sweeping change that dramatically alters the future of American healthcare, right? You need to just come up with what are your aims, how will I measure this, and then just come up with some little small ideas and see if it worked. One doctor, one patient, one day. The barrier to quality should be very, very low. You should just be able to try little tiny things. If you think it would help to get your patients in for pneumonia shots if they have asthma, and you think that phoning them would be a good idea, then just try to call 5 of them and see what happens. If 0 of them answer, then thank goodness you didn't try to call 1,000 people to tell them that they need their pneumonia shot. You need to come up with something else. If you send letters and 90% of them get returned because the address is wrong, then don't send letters to 8,000 asthmatics in your clinic. So the idea is you got to try little tiny things to see what makes a difference. And so you can see we start with hunches, theories, and ideas. You do PDSA, and eventually that can lead to improvement. Okay, so this is really the only thing you need to know from today. So value equals quality over cost. Questions or comments? Yes, sir.
The cost at Banner, how accessible is the charge master to the physicians? Is it accessible online? Or
Very unaccessible.
how do they decide, when they're trying to order a test in terms of that issue? How do they know what is the more expensive or the less expensive?
Yeah, I don't think we have a good way to do that. So one thing that at least gives you like a ballpark, and then you could spend a whole hour talking about the difference between like charge and cost and how much the patient pays, right? So that's very confusing. But Healthcare Blue Book, Has anyone heard of Healthcare Blue Book? So healthcarebluebook.com, you type in CT scan, and it even looks at the area and says this is about what you should be paying for a CT scan. And they actually use it as a negotiation tactic for patients that have high deductible or uninsured. Like Healthcare Blue Book says that I should get a CT for $600. Will you honor this? Of course, then there's like the radiologist fee, which you forgot about, and so actually, when you read this book, which I know you're going to do cover to cover, one of the big problems in American healthcare is that the costs are not apparent to almost anybody, including the patients. Yes? Right. I mean, you just have to do your best. I mean, I think there, and I think a lot of times it starts with just start with the low-hanging fruit. We're not necessarily, we're talking about eliminating the things that we really know won't help to start with. And so I know what that does to the value equation. And then maybe we can get into the more details of the individual expenses. But like medications are pretty transparent. I think most of us know roughly the difference between different imaging tests and the cost. You know, like an MRI is probably like 2 to 3 times more expensive than a CT scan. But it's hard. Yeah. Right. Yeah, what a great example. So you were doing that routinely, but you didn't even know that there was a 1,000 times difference. And actually, some of our resident projects, often this is one of the things that when they come to calculating how much their intervention would actually save, that's often a very hard thing to calculate for exactly that reason. Yeah, let's take one over here.
You were talking earlier about CTs and ABIs. We hear a lot about paying the CT for the 0.4% chance it's an ABI that we don't see otherwise for sort of medical legal reasons. Are you aware of initiatives to protect providers from legal issues in the name of quality?
That's a huge problem. No, not really. I mean, so supposedly the lawsuit criteria is like the standard of care in the community. So, I mean, you can, if you practice in an evidence-based way, you can have an expert say that you're practicing in an evidence-based way, but then there's some other expert that's going to say, well, I order a CT on everybody, so why didn't you? So that's huge. Many physicians that have been involved in lawsuits have told me that I'm naive for saying this, but I just do what's right for the patient and hope that that's, I feel like that's the default. And I guess if someday I'm sued because of that, but I still felt like I did what was right for the patient, I guess I could live with that. Yes?
Do you know of any recommendation or help, I guess, for making things more apparent in terms of the cost of them? I mean, is that something that you think the hospital itself should make it more aware to people? Because I'm a nurse, and you hear things like, oh, well, IV Tylenol costs $1,000, but then it's like, is that really what it costs, or is that what we bill?
Right.
So I think that would definitely make the decision easier from some perspective.
People have done studies. I'm not aware of studies with nurses. That's a really good idea. Like when you click on the Pyxis, it should tell you how much that is. But are you going to call the doctor at 3 in the morning and be like, hello, doctor, I know you prescribed IV Tylenol, but you can save $14 if you, the intern's like, ugh. But they have done studies in physicians where when you order your daily tests or you order a CT, it actually pops up the cost of it. And that they have shown in randomized controlled trial that decreases cost by about 10%. So I would think it would be like 50, so it makes a modest difference when you show doctors how much something costs. Interestingly, they've done studies where they show the patients how much things cost, and patients in general ignore the information, or this is America, right? So we think if we're paying more for something, it must be better. So that's another problem that we didn't talk about today, is that less is more might be something that we all believe, but it's not necessarily something that our culture believes. So there should be more studies on if professionals know the cost of something, do they do something differently? Yes?
Like one of the problems is that cost is divorced from people who are making the decisions regarding care. And so we're not really making informed decisions in terms of the care that we're providing. Do you think that capitation of costs will eventually drive transparency? Because right now there's an incentive from a hospital administration standpoint to increase the level of care that, or the amount of care that's
Right.
provided.
Yeah, so a big part, so the fee for service is a big part of why on that very first curve, US is an outlier. So yes, some kind of, we're seeing in Banner, more and more of our patients are covered lives that Banner is responsible for. And so we're just in the infancy, but now we have like protocols in the clinic for like, you don't need a back x-ray in the first 6 weeks of acute back pain. So in theory, that should make a difference. We actually thought when we implemented our contest at Good Sam that we were going to have a lot of resistance from like the CEO, like you're not ordering CT scans on insured patients, you're actually hurting the bottom line. And we did not hear a peep about that. So I don't think that any healthcare executive, no healthcare executive should exist and continue to exist that doesn't understand that we're trying to provide high value care here. Yeah, in the back.
I think for the residents to know though, in every state is potentially different, in every patient population too. Quality cost, yes, but if different states have different values on different things, so what costs a lot on the East Coast might cost less on the West. So where you practice these differences, the big thing is medication. Currently Medicaid is part of a rebate system in many states, but not all states, and many drugs are much cheaper on Medicaid, and you have to know the system that you work in. So just what you learn today as a resident, you might not apply when you become a fellow or you become an attending, or because every state does have nuances and every system has nuances, so you have to keep up to date and informed about where you're at.
That's great advice. Yeah. Yes.
I just wondered in terms of for physicians or anyone really providing care, the idea of like creating a dashboard for the provider to get feedback. Are you doing that at all at Banner at the individual level, or are doctors getting a sense of what their individual behavior is like?
Yeah, so we have it for a variety of, so now health systems are scored, I'm sure PCH too, by how they do on various like HEDIS measures. So like we're doing a QI project in our clinic about percentage of our diabetics that are over 9 for A1C, and all our residents know their individual patients and what their A1C, what percentage of their patients are over 9. So we maybe have 30 measures that we get feedback, and it's constant struggle to get the individualized feedback for the residents so that they can learn in that setting, but that's happening more and more.
Thank you so much, Dr. Brown.
Thank you.